A warm welcome to the Medico Shorts podcast, brought to you by MedSynapse. Medico Shorts brings to you the latest perspectives, ideas, and advancements for upgrading and improving the way you manage your practice. In today's podcast, we will be talking about the perspective set forth by Deborah F. Weinstein, MD, titled Re-Engineering Graduate Medical Education in a Pandemic, Looking Back and Forward, published in the New England Journal of Medicine on January 13, 2022. In this podcast, we will be discussing the impact of the COVID-19 pandemic on graduate medical education and changes observed in the pandemic that need to be considered in graduate medical education in the future. COVID-19 has caused a drastic impact on healthcare, and graduate medical education, or GME, is not the one to avoid these changes. As the pandemic progressed and COVID patient care demands shadowed other hospital priorities, resident and fellow training diverged from conventional approaches. Supporting trainees' well-being became significant, and teaching and assessment required rapid changes, along with the aspect of trainee recruitment. As patients' demand surged, some physicians were sidelined by illness or quarantined due to COVID-19 exposure, while those with underlying health risks were pulled out of direct care. Medical schools excluded students from clinical services, either for their protection or to preserve stock of personal protective equipment, or PPE. One of the greatest impacts was on providing clinical education. There was a reduced exposure to procedural and routine care, while a greater focus on health equity and cross-cultural care, and new challenges in doctor-patient-family communication came to light. In-person teams were limited to essential clinicians. Judicious use of tele-rounding preserved resources was observed, allowing remote teams to facilitate patient care with prescriptions, literature searches, and other contributions. Just-in-time learning and cross-specialty trainee reassignments were supported and implemented by COVID-focused modules. GME certification authorities also provided flexibility to medical institutions. For instance, the Accreditation Council for Graduate Medical Education and the American Board of Medical Specialties addressed the loss of required training time and specified experiences. They also acknowledged the authority and judgment of clinical competency committees and training program directors to determine readiness for unsupervised practice compared to traditional time and volume-based education standards. In addition, GME recruitment transformed, as virtual visits were replaced by marketing videos, online information sessions, and the use of technology platforms to support tele-interviews. A benefit observed was that applicants could avoid traveling expenses while applying to more programs. Institutions welcomed applicant diversity, while audition electives were shut down for senior medical students, increasing fairness in the application process. In the middle of all the chaos, concerns regarding trainee well-being increased during the pandemic. The fear of acquiring and transmitting COVID infections to family members, amidst shortages of healthcare services for testing and treatment, increased. Voluntary trainees calling for hazard pay, alternative housing, transportation services, funding backup, or home-based childcare were some of the changes observed. In addition, physical and emotional exhaustion plagued trainees along with other clinicians. To increase morale among the trainees, hospitals sponsored appreciation events and online restoration activities, but efforts to facilitate access to mental health services were deemed most important. Although cross-specialty reassignment was one of the prominent sources of stress for trainees, trainee feedback suggested that these interventions successfully supported cross-specialty care. Trainees developed a sense of multidisciplinary approaches to delivering care. Enhanced collaboration and a sense of community among GME leaders across institutions emerged as a positive outcome. The challenges and bright spots of COVID's impact on GME provided important lessons which could protect trainees and their education in the future. Regulatory organizations need to maintain, update, and extend emergency preparedness policies by supporting early graduation from medical school, residence, or both. Processes for issuing medical licenses should be implemented in all jurisdictions. Teaching institutions need to develop principles for the delivery of care if it involves significant health risks to clinicians, including algorithms for clinician reassignment during emergencies. Training programs should create systems for tracking missed learning opportunities while implementing competency-based advancements. Lastly, the formalization of telehealth as a required competency should not be overlooked, even after the pandemic. Crises often highlight the strengths and vulnerabilities of the systems we rely on. The COVID crisis did the same and continues to do so, and hence, we need to evaluate and implement changes occurring around us to strengthen GME fundamentals for the future. This concludes our today's Medico Shorts podcast, brought to you by MedSynapse. Thank you for listening.